this one. Okay, here we go. Introduction to Mathematical Infectious Disease Modeling. What I want to give you is an overview and understanding. Tomorrow morning, you will be playing a little bit with the model, but our role, at least how I experienced it in my career already many years ago when I first worked with some modelers and we designed or used some modeling for different projects. It's not the first pandemic, and it's or big epidemic which I've been involved in my long career. I realized that, okay, the mathematicians who are programming this model, they are very good in programming a model, but they are helpless without an epidemiologist or a public health expert like you on their side, who will tell them what is most likely, how reality looks like, how things should look like. And this is what I want to share with you actually in this lecture, to give you an overview and to show you a few examples so that you have an idea what mathematical modeling looks like, what are the key functions of it on the one hand side, and where the modelers really need you. Because you probably might have heard also in your countries, the leading modelers who were in the media or who were reporting about mathematical modeling are physicists and not necessarily epidemiologists, even though they might have been called epidemiologists in the media. But most of them are physicists or mathematicians who really work on the models, but not independently, but with strong support from people like you. So that's where I want to go, if this allows me to. Okay, so why model infectious diseases? I think this has become much clearer since 1995 from the article which I'm citing here, because you all have seen them. But in general, one would say is to gain insight to mechanisms influencing disease spread, really trying to understand what is really happening, not just my simple picture on day 2 with the different color dots of susceptibles, infected and infectious, or recovered people, immune people, but just to really see what is happening in a society, because the world and even a local society is rather complex. And there, to work with this complexity and to understand this, a mathematical model might help us. It's a nice tool, like to say it this way. It's not reality, it's not the aim just to have a good model. It's a tool to help us to understand what is happening. While we're doing this, we can focus our thinking and can clarify assumptions. We can really get a better overview. This is what this tool can help us with. It can help us explore intervention options to inform policy making, really to have a clear idea what happens. For example, in a pandemic, what will stop this and what will help us to flatten the curve as in the beginning of the pandemic, or which of the measures could be taken away without a too strong effect on pouring oil into the fire and having the pandemic to grow faster again. And what it can also do is it can help us to perform what-if experiments. Real experiments are often logistically or ethically impossible. Yeah, that's what I thought before. Now they're just doing this real-life experiments, just taking everything away and see what's going to happen. Yes, but it's better if you do this beforehand and have an idea, like it's going to go in this direction or in that direction. For all this, a mathematical model with all the right components, which I'm going to show you, might be really useful. So how does there's something in the chat. I fully present. Okay, brilliant. Okay. Oops. How do we get rid of this? Yes. Principles of modeling. How does a mathematical model look like? Actually, the most simple approach I can imagine is like this. It's a black box with lots of formulas inside, normally done by a mathematician or physicist. Okay, and this box only works if we enter the right components, namely data about the disease, data about the population, data about interventions. We need to have really good data. So therefore, actually, you do need public health experts or epidemiologists who can provide the data and who can judge things, who have a as good understanding of what is going on in there. A mathematician on his or her own has their limits at this point. So we have to have the right input. And then we steer it a bit around and we get information on disease spread. Then the model can tell us, with all this input, with all the data for concerning this specific population, it is most likely that the disease is going to spread or continue like as follows. Okay. Yeah, sometimes mathematical models or modeling is regarded, is it an art or is it a science? I think it's a combination of both. Let's have a look. Knowledge, what do we need? We need knowledge or data on the system. We need to understand as good as possible our society, how it works. We also need mathematical or computational skills and resources. So here the mathematician or modeler comes into play. But both of these only can work if you have the values and perspectives. And at the crossroad of all those, you can develop, with input from all these sides, you can develop a model which in the ideal case describes the world as good as possible, so as realistic as possible. Right from the start, I want to point out, like, really even most mathematical modelers clearly state, and I want to state this as well, no models are perfect. None of the models is 100% correct because they are models, but some are useful and they help you understand some of the factors I mentioned before in my first preceding words. Okay. So models, talking about models. Let's talk about models here. Models are used to translate reality into parameters to reproduce observed effects. So actually we're trying to break down our society into specific parameters and try to also reflect and use information from good epidemiological studies, for example, in how these parameters interact. How does our society interact and how do, for example, various diseases or pathogens spread? They are used to predict possible outcomes. The model will help us to say, like, it's most likely to go this way. And if we change something, it's maybe going this or that way. This is what a model can help us to do so. And I just remember having, we, for example, published here this book on Corona, how to understand the numbers and so on. And there are lots of examples also from modeling, how we can better understand what is going on. A third point about models is the models are used to understand significant associations and their effects in causal relationships. This is, for example, when you analyze a study, something like a logistic regression analysis, a logistic regression model is not much different from other mathematical models. It's also a model. It's just not projecting. It's reflecting and explaining what your study said. So This is one of the categories. Models are used to untangle complex associations. And this is if you don't understand or don't really follow so much of what I've said so far, this is the key message. They are there to help you understand complex associations in the past or in the future, projecting for the future. They are always tailored for a certain research question that's necessary because the world is, everybody is different, and every society is different, and every situation and every disease is different. Therefore, you need to adjust it to your needs. And as modelers say, models are wrong. They're not describing reality 100%, but they might be useful because they're trying to describe reality as good as possible. And a very good example for a model is this one. It's not only for kids, but also adults. In Hamburg, we have, I think, worldwide the biggest miniature railway land. It's called Miniature Wonderland, and it looks a bit like this. It's there they try to model, try to reduplicate the world just in small. Indoors, not so good at the moment for Corona, but to visit. But some other time when if you're ever visiting Hamburg, maybe it's a good idea to go there sometime. Anyway, what they're trying is to make the world, to reduplicate the world. This is just a central part of Hamburg with a famous church in the middle and so on. They also have now the new concert hall, the Alp Philharmonie, and things like this. Or IFTH, TK, thank you. Yeah, if you come along, just let us know if you visit Hamburg sometime. Anyway, so this is what the principle of a model. Okay, let me ask you a question. What is this? Who has an idea what this is? This picture.
Bicycle.
Looks like a bicycle.
It's looking like a bicycle.
Yes, it looks like a bicycle. You're using your words really wisely, because it's not a bicycle. It's a model of a bicycle.
Yeah.
And it tells us something close. We understand it's not perfect, it's good enough. And this is how many models get. We don't know, is it this or that type or this type or whatever type of bicycle, but it's a model of a bicycle. It looks like a bicycle. And this is how a model works. A model of Ghana and the spread of Corona in Ghana is not Ghana, but it's a model of it, and it looks a bit like, preferably as pretty much like the situation there. Okay, very good. So the principle, the term is clear now. A model looks like and tries to come close. What about epidemic outbreak models? What are they used for? They're used to understand main factors that influence outbreak progression. We really want to understand how this is spreading. They reproduce real outbreak scenarios. Often you can do it retrospectively, check whether you run your model with data from previous epidemics, and then see whether your model came to similar conclusions as what was observed. They predict outbreak progression within a population, like what I show you a few examples later. For example, also in the COVID situation now, based on what we have learned so far, how is it going to proceed if we do this, if we do that, or if we do nothing? They help outbreaks are used to predict outbreak progression throughout a region or between countries. And that's one of the things we did in one of our projects I'm going to touch on. They estimate the effect of intervention measures. They can help at least in estimating the effect. and they can help inform policymakers as long as they're willing to listen. Okay. So the principle is clear. Now, let me show you a model. How does a model look like? If you've got questions, please always come in. I just don't see you. So just ask loud anytime. So, but I think the principle is clear. It looks like a bicycle, but it's not a bicycle, but we try to make it as good as a bicycle. And, or in this case, like your population, your society, but how can we build this up? There are different sorts of models, but for outbreak control, most of the time, a so-called SIR model is used. An epidemic model, SIR model. The population moves through a series of complements based on the natural history of infection. Do you remember Tuesday's anatomic pictures of an epidemic, which I showed you, with these different dots on the epidemic curve? This is what is happening. You can, at the beginning, 2 years and a few months ago, the whole population was susceptible for COVID-19 because none of us had ever been in contact. Then some people got infected. Oh, as a consequence, and everybody had and still has a very realistic chance to move from this box to this box, right? I hope you agree. And after a while, they are moving from this box to this box. For COVID-19, luckily, at least, we don't have real reports of chronic infection. Usually after the infection, you're removed. Either you're lucky and you recover quickly. Some of them are very lucky and have almost no symptoms. And some others, yeah, are also removed, like about 130,000 Germans have been removed since the pandemic started here. And worldwide, it's, I don't know, we're coming close to 7 million reported cases, and the underreporting, who knows. But anyway, what I want to say is, like, this is the structure, the build-up of a mathematical model for an outbreak progression. This fits very well for Corona. And what is happening in society? If you look at if this represents a whole society, at the start, we were all susceptible. Then suddenly, some people got infected. The numbers increases, while the numbers of susceptibles decreases, of course, and the number of recovered, preferably immune, or removed, this number increases. So this is how things happen. What in the easiest, most simple way, how the distribution in society looks like. Just to give you I can also give you some formulas with this. This has been published in Science for coronavirus. The model, the initial model being used has a very similar build-up: susceptibles, infected, recovered, or removed. And with these formulas, which is more something for mathematicians, you can describe the different developments. Sahid, you want to say something, please?
Yes, I just wanted to say that the infected does not take into consideration the symptomatic and the asymptomatic. We are just assuming that, they're infected.
Yeah, absolutely. Said, you are bringing up a very important point. It's like, in principle, it probably all still, even with this formula, looks a bit too simple for all of you at this point in time. But this is the principle. I'm coming from the black box, was too simple. This seems to be really very simple still, as SIR model. But these are the models which are usually used, and how they can become as good as the miniature wonderland, which I've shown you before. you will see in a few minutes. But there was another question or somebody raising a hand.
Yeah, it's me, Prof. I just want to relate with the black box that you have presented at the beginning. We need three different information to be included in our model, I think, which is disease-related, population-related, and the last one is intervention-related. So in this, maybe I can say we have information about the disease and the population. So how we can entertain maybe the interventions itself in this model?
Yes, I will come to this in a minute, but what I just want to point out at this point in time, the standard model is an SIR model, which has basically, we can always make it more complicated, like the bicycle. You saw the model of the bicycle was very simple. This is the principle simple. You understand your whole society fits into these three boxes, but we can make it a bit more precise. And we will come to this in a minute. There were two more who raised their hand I just saw. Please come forward.
Yeah, I just want to ask that the formulas in the right-hand side, can you please elaborate these formulas, like how they are explained in this?
This is not so necessary for what I want to aim at the moment. I want to give you an overview, and we don't have to build this model. We will work with a mathematical modeler in case, but we need to understand how this works, and that's where I'm aiming at the moment. Sorry, but wait a minute. I'll explain more in a minute. There was one more, Abiat.
Oh, sorry, that was a previous.
Okay.
Yeah, I don't know.
Okay, we can discuss later a bit further. Let me show you an example of one model where I was involved with. This is from the Asia Flucat, the Asia Flucat model, which we developed in preparation for this project, Asia Flucat, where we try to identify or help several countries in the southeast of Asia to see how well they were prepared for the next flu pandemic. And we later on had a good chance to test it. But what I want to show you with this slide only, I'll talk about it in the example later, is like this is an SIR model. But you see, there are lots of other boxes as well, because we can also try to describe the model much more in detail, like exposed, asymptomatic phase, and so on. Different interventions can take place. We can have a box for death and so on. So the model can, of course, be much more complex, but the principle where most modelers refer to is often an SIR model. It's still an SIR model, but with more detail, and we will get there, right? Okay. Still, then these models still can have different functions. In principle, there are more model ideas coming up, also with more sophisticated computers. For example, in-house, we have a group of modelers who follow a very, very different approach with individual agents and so on. But you need a mainframe computer of the whole university to run it, and it takes hours to explain. The two most common other models are deterministic or stochastic models. And if you get in contact with a modeler, with a statistician, mathematician, or physicist who is doing mathematical modeling, you will either find a deterministic person or a stochastic person or somebody who prefers this or that model. Therefore, I just want to give you a glimpse of an idea, like these two models have different principles. At the end of the day, for you and for me, it doesn't really matter so much. It's more the approach, and it depends also what kind of data input you can provide for this. Okay, so a deterministic model, let me just briefly describe, is here parameters are fixed. You're running the model with a particular parameter setting, will always show the same outbreak progression. That's why you get this fixed curves here. So, and deterministic models ignore random effects or the influence of chance. They normally tell you, okay, given your assumptions and your data, if you have no intervention, the epidemic curve will look like this. If you, for example, use different interventions, for example, if you isolate cases, then the epi curve won't reach that high levels already, and it will be a bit delayed. If you use contact reduction or treatment, or if you use all interventions in this model here from Hans-Peter Dürr, University of Tübingen, you would probably see that, yes, with these interventions, you can flatten the curve and you can reduce the impact on society, for example. This was a deterministic model based on these assumptions. Other people use stochastic models. Stochastic models have various parameters are based on distribution showing a range of possible values. So you don't have one curve here. You've got all these gray dots are just representations of lots of different ways how the curve can go. So models are calculated using changing parameter settings to lead to these gray clouds here. And this is good because on the computer, you probably can see it. If I project it, it's sometimes hard to see. And models are run several times, and you might have heard the term Monte Carlo simulation, which is sometimes used for this. My recommendation would be, if you work with a decent modeler, just accept what they're doing, which kind of model they prefer. For us, at the end of the day, it doesn't really matter so much. What matters much is the importance of data. Here again, our Asia Flucat model. And as the Americans, they have a very, I don't know if it's a nice saying, but they have a very good saying is garbage in, garbage out. So if we have bad data, the data is not very useful or has lots of problems, our model results will also be rather questionable. So the most important thing is what we need to do is to produce some, to collect and use the right data to fill the model properly. Okay, which data do we need? What will the modelers ask from us? Outbreak progression depends on four main factors. First, the number of contacts made. That's why you probably heard in this pandemic a lot about contact pattern and contact reduction and so on. Yes, and to be able to judge it, we really need to have a clue about the contact pattern. Secondly, we need to know something about the pathogen. For example, the duration of infectiousness. How long are people infectious? Things like this can change also for different within a pandemic. Like we have learned, the wild type is different from the Omicron type. So we will see. Third factor, big factor is the proportion of contacts who are susceptible. And this definitely changes over time. Changes by vaccination rate over time, by rate of people who got infected throughout the period time over time. So this really is something which is on the move. And fourth, the probability of transmission during case contacts. How likely is it to get infected? And of course, then this changes also due to different interventions. Probability of transmission during case contact differs if you wear a mask, if both wear a mask, if nobody wears a mask, if you're inside, indoors, outdoors, whatever subtype of, for example, corona, the case is infected with. So lots of influencing factors. Okay, how do we get the data? Data sources are really important. And not for all things we will always have good data. Data sources, we can have primary data or secondary data. For behavioral surveys, they might be very helpful. Health facility surveys, they can give us information about contact pattern, healthcare settings. I don't know if you have been much in contact with studies on contact pattern or on contacts. Recently, the last 2 years, the number has increased a lot. In the past, it was very, very limited. And in the future, I project it will also be very limited as well. And secondary data, review of peer-reviewed medical literature. For example, looking at the effectiveness of mask wearing. There's a lot of literature now. You don't have to do this study again. This might probably be very useful. I'm just showing you an example from Cambodia, because in Cambodia, when we did the Asia Flucat project, we had difficulties in finding lots of data, especially about contact patterns. So we conducted a contact survey ourselves, contact pattern in Cambodia. We looked at in 4 places, in Phnom Penh, in Kandal, in Kampot, and in Kratie. And we tried to identify how many contacts by how many participants took place in order to get some information about how do people mix. For example, 60% of contacts were made at home, and 75% of contacts were made on a daily basis and lasted in excess of an hour. This is the situation in Cambodia. In Thailand, it's already, the neighboring country, it's already very different. In Finland, it's certainly very different, and in Nigeria as well. So we have to have a look at this. So we need our local data. We really need to know our society better. How do people mix? We wanted to find out in Cambodia. The mode of household size was 11 persons. So lots of contacts in the household was very common. And the mean age of participants was 46 years of age, was a very wide range. 50% were male. And based on this, you can develop something like this heat maps, where you can see, where you can get an impression at least of who is having contact with whom. And you often see that in many countries that people of similar age have most contacts to people of similar age. Very, very strong, of course, for school kids, but also to some extent in other age groups. This clear? This is a very simple graph. Let's make it more complicated. This is the same for several countries in Europe: Belgium, Germany, Finland, the United Kingdom, Italy, Luxembourg, the Netherlands, and Poland. And of course, this changes over time. If I think of Poland with 2.4 million migrants from Ukraine at the moment, probably the contact pattern is not representative anymore on this slide. But anyway, what I want to show you with this slide is, okay, societies differ, and contact pattern in societies differ. You probably have heard about this funny joke in that early in the pandemic, when they recommended that people should keep at least 1.5 or 2 meters distance from each other. And I think for Finland, the joke went like that they were really shocked that they have to come so close to each other, and because you normally keep more distance. And in Italy, it's a very different pattern. That was a joke, okay? Please don't feel offended. For Finland, for example, we have really good data. This is a recent publication in Nature, just a few weeks ago. It would be much easier than in Cambodia, for example. Here you have the distribution of the population between 12 and 1 o'clock on a regular working day in the Helsinki area based on mobile phone data. And you can really see, like, you can really get a very good overview. But this data is available in some places, not in others. In Finland, it's much easier to have good contact pattern data using, for example, some results like these. Staff in a car manufacturing plant in Wuhan, China, observed social distancing measures during the lunch break during the pandemic. I like this picture, which tells you something about contact pattern and distancing. They took it serious, the 2 meters, with different advantages and disadvantages, but keeping in mind, you have to see, like, how is it in your society? I think that's very difficult to make increase. I don't know. Daphne can definitely tell us more. Okay. From Nature, mean numbers, a publication on, or just a graph, mean numbers of contacts per day for differs also by age or at work. And I can't even read the top one here. Why is it? Can you read the top one here? Why can't I get rid of this? No, I can't get rid of this. Oh, anyway, okay. The next slide shows us in different locations, the contact pattern is different. That's all I wanted to say with these slides. Okay. Any questions about contact pattern? This was only the first one, because contacts are very important for person-to-person transmission and our understanding, and for the model, for modeling. Second factor is maybe the pathogen. That plays an important role. And a good term for this is the basic reproduction number. We mentioned it on Monday. You heard it in the media, but you didn't always really hear it correctly in the media, at least not in the German, English, and Dutch-speaking media, I must say. What does basic reproduction number mean? The definition is the expected number of secondary cases caused by one index case during the entire infectious period in a completely susceptible population. That was easy to measure right in the start of the pandemic, because there everybody was susceptible and you could count how many cases there were, theoretically, because it means not only symptomatic cases, it means all other infections. So the measure, it is a measure of the intrinsic potential for an infectious agent to spread. It tells us something about the pathogen. How good is it in spreading the infection? Syed, please.
Yeah, in the first day, I think there was another element that you added to the definition that I pointed out, in the absence of intervention. So I wouldn't know whether that is really very necessary in the definition. Yes,
exactly. I'm just about to talk about that, because there's something in the chat for sure. And for sure, Daphne is going to comment later. Okay. Yes, it's. I was just talking about, this is the basic reproduction number when there's no intervention. If we, whoops. Yes, and how it works, I think, is clear. We talked about this. If it's bigger than one, it spreads. If it's smaller than one, it disappears. But let me, yes. Let's just first think about this is purely about the pathogen. If you don't do any intervention, it tells you something. How infectious is this pathogen? If you do something, for example, wear masks, keep distance, or close schools, or whatever, then you're not talking about the basic reproduction number, but the effective reproduction number. So effective under these conditions. And the effective reproduction number we can influence on. We have a strong influence on because it depends on our society. But just thinking about the pathogen, we talk about the basic reproduction number. And this differs very much from pathogen to pathogen. I'll come back to this in 2 slides or so. But first, I want to ask you, you as all the students, how you remember 20 years ago, I mentioned this yesterday also, we had this SARS pandemic. And we were able to get this under control. How big do you think the R naught was right in the beginning, or the R naught, the strength, the possibility for the virus to spread? Bigger than 1, smaller than 1?
Bigger than 1.
Bigger than 1.
Yes. Any guess? I know you don't have, you cannot know, but just what would you guess?
3 to 4.
3 to 4, because it was quite effective. Actually, very good. The basic reproductive number was 3, so it was really quite contagious. Every case produced practically 3 new cases. The Spanish flu, 100 years ago, 104. This really caused a big trouble, lots of trouble, and cost lots of lives, as we mentioned. I also mentioned yesterday. How do you think the R naught was for Spanish flu?
I think less than SARS.
Very good.
More than SARS.
You're very well informed. It was less than SARS, was only 2 to 3, somewhere in between 2 and 3. Okay, very good. Oh, wow, this is very good. Hepatitis C. Does anybody have an idea? Hepatitis C was quite a challenge over the last 20, 30 years. What is your guess?
It depends.
You're right. Absolutely. It depends, but the best guess. Okay. No, I want to guess from your side before I go on. Who wants to guess just something?
Maybe 4.
Okay, it's also 3. Why? And yes, and thank you for your comment on 1 or a lower rate. Why wouldn't we think that hepatitis C has such a high R naught? Because I mean, you can kiss somebody with hepatitis C and you won't get infected. It's very, very. You can have very close and intimate contact without getting hepatitis C. But still, the R naught is 3. Does anybody have an idea? Daphne, you're the microbiologist. What do you think about hepatitis C? Why? Did I make a mistake? No, I didn't. Why not?
No idea.
Does this mean that it has the potential to infect more people in optimal circumstances for that disease?
Exactly, and for lifelong. Normally, hepatitis C, if you don't intervene with a new therapy, you would be infectious lifelong, and therefore And with flu, you are infectious for a few days. And so this lifelong, it makes a difference. Exactly. Very good. Very, very good group. HIV is very similar in a way, but with an R naught of 9. Again, lifelong, but even sexual intercourse can transmit the disease, which is very likely not the case for hepatitis C. Measles. What do you think about measles?
More than
12.
10.
Sorry?
I said way more
It's
than
actually very high for measles. I think it's in the range of 8 to 10.
Yeah, it's even, oops, it's even higher, 9 to
Yeah.
18. Measles is
12
one of the very, very infectious
Very infectious.
pathogens. That's why it's a childhood disease, because normally if you're not vaccinated, you have a really good chance on contracting it. And Ebola?
Maybe 2.
I'll say 3. I'll say 5.
6.
Hey, no, you were right with 2. It's a limited period of time, and there it really helps to keep 2 meters distance. And last but not least, COVID. I just changed it. I had a number there, but I put a question mark because it really depends on which variant you are. And originally it was seen as also around 3 or 4, something like this. But with the Omicron variant, it seems to be higher. So so this is a very important factor to look at. Okay. So in contrast to the R nodes, as Said just pointed out, we've got lots of factors in the chat. Great numbers. You put numbers, you wrote numbers. Okay. Thank you very much. Thank you very much for cooperating. Said wanted me to talk about, and I voluntarily also want to talk about effective reproduction number, because this is what is often referred to in the media as the R number or whatever. It's the effective reproduction number, the estimate which shows changes in R naught over time, for example, due to application of intervention measures, what we do. And the same principle applies, but now it's not only for people for a wholly susceptible population, but it takes into account the fact that due to, for example, vaccination, due to mask wearing, due to distance, keeping distance, contact reduction, we, due to all these measures, we limit the transmission to these other individuals. And this actually is what we talk about when we talk about the effective reproduction number. What happens if you reduce measures? Of course, the effective reproduction number increases. If you increase protective measures, the effective reproduction number decreases. And that's how there's a strong interplay. And it will be really exciting. I mean, for an epidemiologist, it's really exciting what is going to happen during the next few weeks. And it will be most exciting if I don't get infected during this period of time. But it's lots of things. The risk is really increasing for all of us. It will decrease exactly if we increase the vaccine level, the contact. If we reduce contacts, then we will decrease the effective reproduction number. Perfect. Okay. The basic reproduction number can be calculated in a simple way, but this is not really our issue here. What is really interesting is the outbreak progression in an SIR model. We described this before. And you can also use this effective reproduction number or the basic reproduction number to calculate the critical vaccine coverage. If you want to find out how many people need to be vaccinated in order to reach something like herd immunity so that the disease doesn't spread anymore so fast, you see that for influenza, seasonal influenza, already a small proportion of society will help you to stop the strong effects of an epidemic. For smallpox, you needed more than 50%. This could be eradicated because it all was relatively easy. For measles or for Omicron, which is in somewhere being described at a very higher level, it's somewhere in between maybe mumps and measles nowadays. You would have to have a vaccine which stops the spread, and you would have to have a very large part of your society vaccinated. Okay. Why? Because we want to achieve this, to flatten the curve so that society is not so strongly affected. And yeah, we want to delay this, and we actually delay it into the spring and summer so that then the climate would help us as well. Okay. One example, the Asia Flucat, as I said, was our project with 3 European partners and 6 Asian partners, where we tried to apply a model like this. And I want to show you how to use this kind of model. Oh, I still have 19 minutes, so I can relax. Okay, so how does it go about if you use a model? What can it be used for? Okay. Within this project, the background was Southeast Asia plays a central role in emerging diseases. Very often, it's the starting point. Health systems capacities can be stretched by pandemic scenarios or large outbreaks. That's what we learned. And the aim was to estimate and compare the resource gaps and potential mortalities associated in response to pandemic influenza in Southeast Asia. We wanted to see how well are they prepared and where can they improve. And for this, it would be probably good to collect first health resource data and then use this to apply an SIR model, or you can also call it SEIR model when you've got exposed in there. And to look at resource needs, gaps, and attributable mortalities. So you can actually make a model which describes a society and then let a virus go through this model, like through this society, and see how well are we prepared. Okay, this model is programmed to estimate the potential number of resources needed to respond to a pandemic influenza outbreak, show the effect of potential resource gaps on outbreak progression and health outcomes, and highlight where resources and which particular resources should be increased and improved. That's what we looked at. And here you see now in big our little model. It's an SIR model, but with different steps. It was a deterministic model, described all by differential equations, and was tracking the number of people in each compartment over time. So we try to describe it a bit more, like susceptibles could be exposed. Some of them then would develop in the beginning an asymptomatic infection, which could stay asymptomatic. Therefore, they wouldn't really get in contact with the healthcare system and would recover afterwards. But they could also have mild symptoms, and they could be treated with antivirals, or they could not be treated with antivirals. And with mild symptoms, you normally recover. But it could also be a critically ill person. And there you have different ways things can go. With antiviral treatment at home, or without antiviral treatment at home, hospitalized and infectious, and on ventilation and infectious, and therefore you would be isolated and so on, and some of them would recover and some wouldn't in the critically ill. And this is what we actually see, these compartments, at least we would see now also with COVID, isn't it? These numbers here probably have increased with Omicron, while with the Delta variant here, this part was much bigger. Okay. Okay, do you understand the model now? How the theory of the model looks like?
Yes, but I have a question maybe from my side.
Okay, after, okay, then thank you. Let me just give you a model example. This model is programmed to, we looked at that. And let me just, okay, you can, some of the results, just as a simple example here. Yeah, we could use this model to look at, for example, the advantage was it looked at lots of provinces and countries. So we could zoom in. Let's zoom into one province in northern Thailand, in Phra province. And here you see the size of the population, how well they were prepared, so like how many antivirals they had, how many hospital beds they had, how many ventilators they had. And here is the outcome of the model. If we run in this province the model for this epidemic, we would see how many symptomatic infections we would have, how many critical case hospitalized we would have, and also a very, very minor number of people who would have died. It's not so easy to see, while at the same time we would see how well they would be equipped and at which period of time different interventions would help. And the results of this model for this province show us, hey, a quarter would symptomatically infected cases. The maximum number of observed cases would be this number, and 49 cases would die. The number of beds and ventilators would be sufficient, we would see, but antiviral drug stockpile would last for most of this epidemic, and the resource gap would be antiviral treatment sources. Some would be additional ones would be needed. So this province in the north of Thailand at that time was pretty well prepared for a flu pandemic. Going to the south of Thailand to another one, another province, a bit bigger, not so well prepared, relatively speaking. We would see this epidemic curve, and we would see even a relatively strong blue line here of cumulative deaths. Again, about a quarter would symptomatically get ill. We would see more than 500 deaths, very likely. It's not going to be 502, it's not going to, but it's going to be the magnitude. It's bigger than in the other. Antiviral drug stockpile would last until day 90 only, so long time in the, for a longer period of time, they would be run out of resources. That's what we see also, the resource gaps for ventilators, for treatments would be pretty high. And by increasing resources, we calculated that quite a few deaths could be prevented. If you give this information to policymakers, this could be used, and especially if you look at a grand scale. Here you see the, maybe I'll go, for the first one with the deaths for the whole region. This is Laos, this is Cambodia, this is Thailand, north of Thailand, south of Thailand. This is Vietnam. We also had 2 parts of Indonesia in there, and we also had the whole of Taiwan. And you could see that, for example, within Thailand, you've got differences, so that Thailand, for example, could react much better in some, to equip some regions better. While you would see that Laos and Cambodia certainly have a long way, and they should ask donors to help them, to support them in preparing better for a pandemic like that. That was one of the conclusions. Okay, limitations of this kind of model: results are highly sensitive to model parameters, garbage in, garbage out. the better the data, the better it is. And as I said, for a Helsinki area, it's very easy to get good contact data. No age structure in the model, because it was a deterministic model, and it assumes each province is a closed population with no geographical diffusion of the epidemic, and it would be much better that we realize infectious diseases do not respect boundaries. Okay. Conclusions. The findings have important implications for where, both geographically and in terms of which resource types investment is most needed, and effective mobilization of resources across administrative boundaries could go some way towards minimizing avoidable deaths. So we can do something. Okay. Okay. This was an example. Now let's have a look at COVID. How does it look? Do recent experiences look like? The bit more sophisticated model here is also an SEIR model, looking at infected, infectious, symptomatic, latency period, incubation period. You can see what we've learned right on the start, but these don't overlap. These do overlap, and therefore, how could this model be used? For example, some colleagues who published in Science, their first results could project on the beginning, at the beginning of the pandemic, how it would proceed if different interventions no interventions, some interventions, and strong interventions would take place, and you can project how things are going to develop. You can even, they also looked at the effect of contact tracing or different interventions, and you can then confirm it or test it on, for example, here some results from Denmark, viral tests. How many infections do we miss? On you can test it with other results, how big, for example, the underreporting is in different phases. This is very important because all these factors in the pandemic have changed a lot. Sorry for also this slide with German title, but it also tells you only it's the proportion of tests on all PCR tests which were done in Germany per calendar week, which were positive. So in the beginning, you had a very relatively low rate of positivity, meaning like most of the cases would be found and the underreporting would be small. At the moment, the underreporting must be enormous and nobody cares. Anyway, okay. Let me just skip this. It's a bit complicated in terms of time. So here from another paper in Nature, you could see that, for example, the reproduction number can be influenced, thus the effective reproduction number, by different intervention. Self-isolation, social distancing, school closure, public events banned, and complete lockdown, as we also saw from Sovi a bit, like with a different combination of these factors, we could reduce the effective reproduction number quite effectively. What is going to happen if we're going this way, if we're going that way? We're lifting all of it, and preferably at once, as we're doing at the moment. How is this going to affect? While on the other hand, to reduce, there's only the seasonal effect, which we are hoping for, that it will have a strong effect, but we don't know to which extent. Okay. Therefore, what we want to do is, in our model tomorrow, after you overnight have digested, like, what is SIR model? Okay, in these boxes, how do people move from this box to the other? And after that, we want to have a look at, for example, this, a list like this, or preferably Sovi's list from the previous lecture, on how do different interventions have a different effect on your population in one of those models. It's really like picking what kind of how fast you train in your miniature railway really runs, and you will see how long it will go well or when it will fall out of the curve. That's what I was trying to give you as food for thought for tonight. Think about, just to have an idea, like how mathematical modeling in principle works. In principle, very, very easy. To be precise, maybe not so easy after all, but we're going to try it out. Now it's time for questions. I saved 5 minutes, but maybe we can also have more questions if you want.